I'm really excited to talk to you all today about contraception and reproductive planning and IBD because I know that we've brought this up over the past several discussions about talking to patients and changing therapy for women who are planning for pregnancy. But as I'll go through, unfortunately, women are not great planners in addition to being non-adherent to their IBD medications. They're often non-adherent to their contraceptives. So I have no financial disclosures. And my objectives of this talk are to introduce two very important questions to ask every reproductive age woman with IBD, discuss the evidence behind the importance of these questions, and then review some management options for patient responses. So the first question is, would you like to become pregnant in the next year? And this isn't of my making. This is actually a public health initiative from the Oregon Foundation for Reproductive Health, and it's called the One Key Question. And what this comes from is a toolkit for primary care providers and medical subspecialists such as yourselves in order to prioritize this in your patient interactions. And I'll go through why. So the relevance of this is that most women in the country, outside of the great state of Utah where we have a high birth rate, most women want 2 children. And in order to achieve 2 children, women spend about 5 years either trying to get pregnant, being pregnant, or recently postpartum and lactating. But they then spend 30 years of their reproductive lives trying to prevent a pregnancy when they don't want one. And when you look at the bulk of the IBD literature on reproductive health, it's all focused on the 5 years of trying, being, or after. And it's not addressing many of the questions that women have about the rest of their reproductive health and how this interacts with their lives outside of pregnancy. Now, most women do want to plan the timing and spacing of their pregnancies for both social and economic reasons, but there's a greater public health issue here that we're trying to address because we know that adverse maternal and child health outcomes are directly associated with pregnancy intention. So the women who don't plan their pregnancies are more likely to delay their prenatal care, have premature birth, and also the children that result from these pregnancies are more likely to have negative physical and mental health effects. This is such a great public health issue that it was one of the initiatives listed in the Healthy People 2020, but we are nowhere near on track to reduce the unintended pregnancy rate by 10% in the next decade. Now, we in the US are really poor at planning pregnancy. Over half of all pregnancies in the United States are unintended. This means that they're either mistimed, meaning that the woman wants another pregnancy eventually, but not in the next 12 months, or they are unwanted, meaning the woman never wanted to become pregnant again during her reproductive life. And so you can imagine when we're talking about our IBD patients and talking to them about certain medications that they might be on if they're planning for pregnancy or not use if they're planning for pregnancy, women aren't great planners. And so we need to ask the first questions ahead of time to figure out if they're even at risk for an unintended pregnancy. So the relevance for your patients is that by age 45, more than half of all American women will have experienced an unintended pregnancy. 1 in 3 American women will have had an abortion, and this includes women with IBD at the same rate as the general population. And more than 99% of American women who have ever had sexual intercourse will have used at least one contraceptive method. And so as an OBGYN, I can ignore half of the population and not talk about men at all, but I know that all of you see women, and so these are relevant topics for your patients. So we've talked overall about how pregnancy must be planned for women with IBD because we know that active disease at the time of conception is associated with adverse pregnancy outcomes, such as recurrent flares in pregnancy, miscarriage, preterm delivery, low birth weight, in addition to the adverse outcomes that could occur with unintended pregnancy that we already talked about. So what do we do to address this huge public health consideration and help our patients plan for healthy pregnancies? We know that contraception works. So as you can see on the pie chart on the left, of the women who are at risk for pregnancy, about 65% of them are consistent contraception method users, and they account for only 5% of the 3.1 million unintended pregnancies that occurred in this year. Whereas the other third, who are inconsistent or non-users of contraception, account for 95% of the unintended pregnancies. What happens as a result of these pregnancies is really based upon sociodemographics because we know that women with the means abort their unintended pregnancies, whereas those with the least economic means, those that are least able to care for another child in their lives, are most likely to go on to have a live birth. So when we talk to women about contraception, we talk to them about efficacy. And this goes back and is a great follow-up to the non-adherence talk, because we know that the methods with the least failure rates are the least user-dependent. So the ones that are IUDs, implants, sterilizations, once the method is in place, the woman can forget about this, have less than 1% failure rate over 1 year of typical use. Whereas combination birth control pills, which are the most commonly used hormonal contraceptive in this country, have an 8% failure rate over 1 year of typical use. Condoms, 15%. Natural family planning or the rhythm method, 1 in 4 women will become pregnant over 1 year of typical use. And so this isn't to say that women all have to use these highly effective methods, but they have to be okay with the potential for an unintended pregnancy if their method fails. And for some of our patients with IBD, this isn't okay. So I want to spend a couple minutes going through these different methods so that you're aware of what women are using, how they work, and what's actually in them. So as I said, the combination birth control pills are the most commonly used hormonal contraceptive. There are other ways to get the same drugs, though, through the vaginal ring or through the birth control patch that's on the market called Ortho-Evra. But all these are highly user-dependent, which is why they have the 8% failure rate over 1 year of typical use. They require a daily, weekly, or monthly interaction with the patient in order to make this an effective means of contraception. Now, all of these methods are the only methods on the market that contain estrogen. And estrogen gets a bad name in the media because we often talk about birth control and blood clot, or in patients who've had prior strokes. These are the only methods that are off the table for women who have those high-risk situations. They provide great ovulatory suppression for women who have pain with ovulation or ovarian cysts. And there's also the option to continuously cycle these methods. So for women who have symptoms with their menstrual cycle, this is a way to make those symptoms improve. There are progestin-only pills on the market for women who are still committed to taking a pill but have a contraindication to using estrogen. These are most commonly used in this country in the postpartum period, especially in lactating women. They do provide inconsistent ovulatory suppression, though, and can have irregular bleeding patterns. So for some women, that's not acceptable. We do have one injectable on the market, and unfortunately my whole slide did not show up, but it's medroxyprogesterone acetate, or Depo-Provera. This is a 12-week injectable, and so it requires the woman to go back to the clinic every 12 weeks for an injection, which is why it has about a 3% failure rate with typical use. It's the only contraceptive that's a true progesterone, and this is why you see the side effects of increased appetite and weight gain in some patients with this. The other methods all have progestins in them, which are typically androgen derivatives, and so it's a different side effect profile from this. This method is great for women who need consistent ovulatory suppression, and it has a high rate of amenorrhea. So we commonly use this in women with medical comorbidities, such as epilepsy, in patients who have seizures that cluster around ovulation or their menstrual cycle. This can improve their quality of life. We do, though, consider the issue of chronic steroids in some of our patients because we know that there's some reversible bone loss with long-term use of Depo-Provera. And so in these patients, we talk to them about potentially using add-back estrogen with them to protect their bones. We have one subdermal implant on the market called Nexplanon. This is FDA approved for 3 years, and this is also a progestin-only method. It provides excellent ovulatory suppression, but can have some inconsistent bleeding profiles, which may make it less acceptable than some of the other highly effective methods. There are 2 IUDs on the market that are hormonal-based, and they both have levonorgestrel in them, which is another progestin. The Mirena IUD is the 5-year IUD, and then the Skyla is a recent addition, which is a 3-year. They have inconsistent ovulatory suppression, but what makes them so attractive to women is that they have fewer bleeding days on these methods. So for women who have painful periods, these are a great option for minimizing that. We have also used these in our endometriosis patients to minimize some chronic pain for them. And the one other IUD that I do want to mention here is the copper IUD, or Paragard. Even though it's a non-hormonal method, it's one of our other highly effective methods. It's FDA approved for 10 years, but it doesn't provide any ovulatory suppression, and women do still menstruate on this. And so there is the potential to increase in, bleeding and cramping with this, which may not be acceptable for women who have heavy periods. So how do we decide how to talk to patients with medical comorbidities? The CDC used this information to modify some medical eligibility criteria that were published by the WHO many years ago. And what they did is go through all of the different medical comorbidities that reproductive age women are faced with, and then rank the different contraceptives based upon evidence and expert opinion. And inflammatory bowel disease was one of the ones that was added when this was modified for the US population. You can see it listed as the second one down. And then this goes through the different contraceptive methods and ranks them 1 through 4, with 1 being a green light, where the benefits definitely outweigh the risks, and red being never use this in these patients. And now this is something that is downloadable to your iPhones or iPads for use in clinical care, and it's on the CDC website. But as you can see on the far right for IBD patients, implants and IUDs are ranked level 1. These should be first-line agents for our patients because they provide the most highly effective, reliable form of preventing pregnancy when it's not planned and have the fewest side effects for our patients. Progestin-only pills and injections get a level 2, primarily because there's not a lot of robust evidence in use in our patients, although it does not mean they're not safe to use. And then the combination pill patches and rings, these are the estrogen-based ones. They get a 2/3. So for most of our patients that are well controlled, they're safe to use. But for some of our patients, it's a level 3. And we get a little bit more guidance and clarification later on in the document, where they say for women with IBD with increased risk for venous thromboembolism, for example, those with active or extensive disease, recent surgery, immobilization, chronic corticosteroid use, the risks of combination methods generally outweigh the benefits. And so this isn't to say that you should go home and tell your patient who's now having a new flare and is on the pill that she should stop her method. Please, as a family planning person, don't do that. Have her meet with her reproductive health provider and talk about what the safest method for her is, especially if her disease is poorly controlled, if she's planning for an upcoming surgery, et cetera, so that she can safely manage her disease and not put herself at risk for higher risk for a thromboembolism. And I also just want to talk about the venous thromboembolism risk in general, because as I said, there's a lot of media in this country about the birth control pill and blood clots. So baseline risk for a blood clot in the general population is 4 per 10,000 women years. So it's not a common occurrence. And yes, the combination pill can increase your risk, but it's still only 9 per 10,000 women years. Whereas if you look at pregnancy, it's 20 per 10,000 women years. So if you're talking to a woman who's afraid to start a combination birth control pill because of the risk of blood clot, if the alternative is an unintended pregnancy, her risk is significantly higher. Now, where things get a little bit muddy is when we start talking about active IBD. To the best of our knowledge, the risk is about 12 to 13 per 10,000 woman years. So your risk with active disease is higher than the baseline population. But what we don't know is what the additive risk is between an estrogen-based contraceptive and active disease, and whether that might push a woman over a threshold. But what's even more important to consider is what the additive effect of active disease and an unintended pregnancy could be. And this is where a counseling intervention on your part is necessary. So what are women with IBD actually using? So the only study that had really published on this before was in 2007 by Mari, looking at contraceptive utilization both prior to diagnosis and after diagnosis compared to regional and national data. And what she found is that women with IBD, both before and after, were less likely to use contraceptives than the general population. In addition, they were primarily relying on pills and condoms, which, as we already showed, can have higher rates of failure. So in order to update these data, especially since many of the methods have changed over the past decade, we talked to women who were at risk for unintended pregnancy. So these are women who said they did not want to be pregnant in the next 12 months, but they were in a heterosexual relationship, they were regularly sexually active, and they were regularly menstruating. And what we found is that 23% of these women were relying on no method at all. 19% were relying on condoms only, which have the 15% failure rate. And so when you're talking to patients who say, oh, I'm not thinking about pregnancy, I'm not planning for pregnancy, 42% of them are putting themselves at high risk for an unintended pregnancy. And when we looked at factors associated with non-use of a contraceptive method in this population, we found that prior IBD-related surgery and current biologic therapy use actually put them at higher risk for not using any form of contraception. And so these are the patients that are with more active disease, more at risk for pregnancy complications, and yet not having these conversations with you about whether this is a good idea. So it would be great if we could all silo our care and just talk about what our specialties are, but unfortunately, women with IBD desire information from you, from their gastroenterologist, on both pregnancy and also contraception. And so having some understanding about what women are using and what the efficacy is important for your counseling with the patients. In addition, many women are not initiating these conversations. They don't know that they need to. They don't know how to. They might not feel comfortable doing so. And so it's important for you to ask the question every single visit, because this is a moving target for women of whether they want to be pregnant in the near future. Now, the Australian group had done the CCP No survey and had developed the educational interventions in order to focus on some of these issues, but contraception was not one of their focuses. So we need to work on better educational interventions, not only for our patients, but also for our providers. When our group looked at reproductive health documentation, what we found is that contraceptive method documentation is actually sparse by gastroenterologists, and this included women who were on methotrexate. And ironically, next door, there's a conversation about avoiding medical malpractice issues in IBD. Unfortunately, reproductive health is one of the most litigious issues in this country. And so if you're not documenting the contraceptive method plan for a patient or a referral to somebody who could make that happen and prescribing the methotrexate, you're setting yourself up for a malpractice concern. In addition, the study also found, again, that most of the conversations were primarily patient-driven. So few providers were actually initiating these conversations with patients on a regular basis unless the patient brought it up. So this is going back to the One Key Question initiative and why this is so important. Many women are not seeing a reproductive health provider as frequently as they're seeing you, especially if their disease is poorly controlled. And so asking them every single visit, would you like to become pregnant the next year? It's a quick 2-second intervention. It tells you if the woman is thinking about this but hasn't brought it up so that you can talk to her about whether this is a good idea in the setting of her disease, whether she's seen her reproductive health provider, start her on folic acid. For a woman who says, I'm not sure, I'd be okay either way, she also needs to start acting pregnant before she gets pregnant. If a woman says no, asking her if she's satisfied with her method of contraception and what that contraceptive method is. If it's not a reliable method when she's on a medication that she should be using one, making sure that she makes the connection with her reproductive health provider if you're not comfortable providing that contraceptive education is an important next step. So in the last few minutes, I just want to focus on the next question, which is also related. Asking women if they notice any cyclical patterns to their disease-related symptoms. And this isn't a new issue because we brought this up before, and Dr. Kane was in the first study on this, showing that women have cyclical related symptoms to their IBD patterns. And we primarily see this in Crohn's patients and around the time of menstruation. But what these studies didn't do was talk about what we could actually do to improve the quality of life for patients who do have these symptoms, because we know that even in women who have well-controlled disease, if they have a cyclical pattern to their symptoms that's menstrual related, they have a lower quality of life index than others. In the family planning world, we commonly use hormonal contraception for non-contraceptive benefits. So we use it for cancer reduction, for bone loss prevention, for treatment of acne, for epilepsy, as I already brought up. And yet this had never been looked at for managing some of the cyclical related symptoms that women with IBD have. And so we asked women, what are they using, what have they used, and what are their effects on their cyclical symptoms? And what we found is that 20% of hormonal contraceptive users actually said that their cyclical IBD-related symptoms got better with their method. The majority of patients showed no difference in their symptoms. And this is actually an important counseling point too, because many women are afraid to use a hormonal contraceptive because of myths or concerns about adding another drug and making things worse with their IBD symptoms. And so reassuring a woman that she can use an effective form of contraception without a negative impact on her disease is important for her reproductive planning. So the clinical bottom line of this question is if a woman doesn't know, if you're not sure what the triggers are, if she's having a hard time getting her disease under control, have her keep a menstrual and symptom diary. And there are some really easy, nice apps out there, like Clue is one of the best ones that we use for women with medical comorbidities, because it allows them to modify the app so that they can track things that are important for their disease. And that way their awareness of the menstrual cycle and what's coming on can actually alleviate some of the anxiety around, is this my period and the diarrhea associated with this, or am I going into a flare? And then if a woman does note cyclical symptoms, regardless of her need for contraception for reproductive planning, potentially considering a contraceptive method to manage her disease-related symptoms and quality of life, or talking to her reproductive health provider about this. And so in summary, every woman, every time, every visit, asking, would you like to become pregnant the next year? And then considering menstrual timing or hormonal changes with symptom reports so that we can maybe make a difference and improve the quality of life for our patients. And so with that, I'll end, and I thank you for your time and for your attention, and I hope that I've provided enough background and evidence for you to consider this in your individual practices. But I also want to open the conversation about how we can spread this beyond the room and how we can work together as an interdisciplinary team to improve the health of our patients and subsequently the health of their families. Thank you.